So my topic today is a left bundle optimized ICD in suboptimal LV lead placement. So this is something that we have done as a bailout strategy when we had a not so optimal LV lead placement. So a little about CRTs in the beginning. So what exactly is a CRT? So what exactly is a CRT? So for over 2 decades now, we have been using cardiac resynchronization therapy as a standard non-pharmacological therapy for heart failure patients with a reduced ejection fraction and ventricular conduction delay. So the main idea behind a CRT is to resynchronize the dysynchronous wall motion of the left ventricle using pacing and in patients with heart failure and ventricular conduction delay. So approximately this number may be higher, but approximately about 15% of CRTs, conventional CRTs using biventricular pacing, have suboptimal results. So and mainly the reason behind that is mainly seen to be the LV lead placement, and the culprit being the LV lead in suboptimal CRTs. So with the factors that contribute to this are varied CS anatomy or CS dissection, which is a common occurrence with difficult CS anatomy, and high pacing thresholds, phrenic nerve stimulation. So there are some more factors that contribute to suboptimal LV lead. Suboptimal LV lead placement is also one of the factors limiting the biventricular pacing. So with the limitations being said, I want to turn our attention towards conduction system pacing, because I truly believe that conduction system pacing is the future, and we are working towards it. And conduction system pacing has an emerging role in providing said cardiac resynchronization in patients having a heart failure with reduced ejection fraction and interventricular conduction delay. So my case today specifically talks about the use of conduction system pacing in cardiac resynchronization when there is suboptimal LV lead placement. So my case today is a 72-year-old female with a known case, who is a known case of diabetes mellitus, systemic hypertension, non-ischemic dilated cardiomyopathy. She came with complaints with one episode of syncope and NYHA class 2 dyspnea. Her echo showed severe LV dysfunction with an EF of 27%. Her ECG, her basal ECG, pre-procedural ECG, showed a sinus rhythm with LVBB morphology with a QRS duration of 160 milliseconds and a left axis deviation. Her plan was conventional biventricular pacing, CRTD. So as you can see, we yeah. So we did a coronary angiogram to show that she had normal epicardial coronaries. This is a levophase angiogram of the filling of the RA via the coronary sinus. Okay, so in the first slide of the first slide among the 5 slides, we can see we used a MB2CS delivery system to inject contrast into the coronary sinus. The second tile shows you the CS with its tributaries, the posterior and the posterolateral veins. So on the third tile, you can see us trying to wire the posterolateral vein. So we had some difficulty trying to wire the posterolateral vein, and I think we pushed a little too hard, and we eventually suspected a CS dissection, and that we confirmed with a contrast injection, and indeed it was a CS dissection. So finally we decided to place the CS lead in the middle cardiac vein, as you can see in the last tile. So once the LV lead was placed, we programmed LV VVI alone pacing. But as you can see, the 12-lead ECG showed a broad complex QRS and a negative QRS complex, particularly in leads V1, 2, 3, and AVF. We then proceeded to place a 6935 69 centimeter single coil DF1 lead in the RV apex, and biventricular pacing was performed. So this is the biventricular pacing traces. So we programmed various different VV delays to achieve a narrow QRS complex, but as you can see, like the QRS is still quite broad and still negative in leads V1, 2, 3 and AVF. And the measured left ventricular activation time was greater than 100 milliseconds, which was not satisfactory at all. So then with such unsatisfactory results, we decided to re-strategize, and we decided to opt for a CSP optimized ICD rather than the originally planned biventricular CRTD. So since the biventricular pacing was not so different from the intrinsic, we decided to place a left bundle area lead. So we used the Select-Sure 383069 centimeter lead to pace the left bundle area using the C315 his sheet. Septogram was done to ensure that the tip and the ring electrode had deeply penetrated into the septum, and there was good current of injury. The sensing also was good. We measured R wave amplitude of 10 millivolt. So we were as you can see, we were able to achieve a quite narrow QRS complex with a QRS duration of around 100 to 120 milliseconds. In this. So the device output was around 3 volt, and the measured R wave amplitude was around 10 millivolt, and the threshold was at 0.75 at 0.4 milliseconds. So since we got a better narrow QRS complex using the left bundle lead, we decided to remove the LV lead altogether, and this was the final result. We have a DF1 RV coil lead, a single coil lead, and a left bundle lead to pace the left bundle, and a RV lead. This is what we finally ended up with. As you can see, we were quite satisfied with the results that we got. The mode was set to a DDD. The lower rate was at 60 beats per minute, and upper tracking rate was at 130 beats per minute. The paced AV delay was 110 milliseconds, and the sensed AV delay was at 100 milliseconds. So this was the post ECG. As you can see, we achieved quite a narrow QRS complex, and it was much narrower than the biventricular pacing. So this patient came back. The procedure was done in 2021. She had came this year in the 9th month, and I am happy to say that her symptoms have improved, and she has an improved LVEF of around 33% also. And yeah, we were quite happy with this case for this patient. So the take-home message being that suboptimal LV lead placement. What I mean by suboptimal means that, like, when you don't have a narrow enough QRS complex to correct the electromechanical dysynchrony, that should not be accepted in a CRT. And CSP assisted, conduction system pacing assisted ICD is a viable bailout strategy in CRTD failures, and it definitely did serve us as an alternative strategy when there is technical and anatomical difficulties. So yeah, thank you.
Yes, thank you so much, Shimran John Alexander. And can I just ask, can you just please come back to your stage, please? Yes. So to present a memento for Shimran, let me welcome Mr. Radhakrishnan from our... Yes, can we give him a big round of applause? And thank you. You are literally the first speaker, and thank you so much for coming forward. And by that, let's move on to the second speaker of the day, Abhisha S. on the topic conduction system pacing in post-AVR from Madras Medical Mission, Chennai. Can you give her a big round of applause and welcome her?
Good morning, everyone. I'm Abhisha, cardiac technology student from Madras Medical Mission. Let me have a brief introduction to cardiac conduction system pacing, followed by the case presentation. The aim is to provide physiological ventricular activation by directly stimulating the conduction system. So, current modalities include left bundle branch pacing or his bundle branch pacing. It is shown to be safe and more physiological alternative to biventricular pacing. In conduction system pacing, we place a lead in either his bundle or to the left bundle. So I think it's really important to know the concept of predestination. As you see in this image, the his bundle is divided into two zones. One is a branching portion of the his bundle and another one is penetrating portion of the his bundle. The thing you really understand from here is it's not like just sorry. So the concept of predestination is here you can see it's not like just a bunch of fibers which simply goes and get bifurcated. It is a whole bunch of fibers which is predestined for either his bundle or left bundle. So recently studies reported that for left bundle branch block, we can correct it by doing his bundle also. So the thing is, you have to place the lead beyond the block just like bypass grafting. Here comes my case example. A 70 years old male having diabetes mellitus and systemic hypertension, a known case of coronary artery disease who underwent coronary artery bypass graft in 2002. His echo findings shows severe calcified aortic stenosis, moderate LV systolic dysfunction with ejection fraction of 35%. And he underwent transcatheter aortic valve replacement using MyValve Pro Meridien. So this is a pre-TAVR ECG which shows sinus rhythm with left ventricular hypertrophy, and also you can see in the lead 1 and AVF there is a left axis deviation. So this is a post-TAVR ECG which shows sinus rhythm with left bundle branch block. So what really happened here was, as you see, conduction system penetrate through the membranous septum, and membranous septum is just located in the junction of the RCC and NCC. While doing TAVR, the mechanical compression by the placing the valve will disturb the conduction system or the area around it. This is a 24 hours Holter monitoring shows that left bundle branch block and intermittent AV block. Here you can see the HP interval which is prolonged of 131 millisecond. So we plan for left bundle branch pacing. As we discussed before, recent studies that shows left bundle branch block can be corrected by his bundle pacing. But in this case, patient already underwent TAVR, so we plan to perform left bundle pacing because his bundle pacing would be really challenging for this patient because of the anatomical distortion. Here we use C315 His catheter and 3830 select secure lead for this. Before screwing, we just expose the lead to the right side of the interventricular septum and start pacing. While pacing at proximal interventricular septum, we have a notch in V1, that is the W pattern. You can see the notch at nadir of S wave in lead V1 and tall R wave in lead 2 and discordant AVR and AVL. This means you're in the right side of the interventricular septum. Okay. So here is the anatomy of left bundle. You can see in RAO 30, the right bundle is superior to the left bundle. Screwing from proximal septum will give you the way to reach the left bundle. And these rows you can see. While we pacing in the RVOT anterior and posterior, the AVR and AVL will be negative. But when you pacing in the parahisian, it will give the discordant morphology. So from the target site, rapid turns were performed, resulted in PVC that you can get a R wave or QR pattern in lead V1. That means you are in the left bundle. So further rotation was stopped because when you give further more turns, it will perforate it or you will enter into the left cavity. So this is a post-screw EGM. You can see there is a QR pattern in V1, and from the stim to the EGM there is an isoelectric line, which denotes you're done the left bundle selective pacing. And as we all get the successful morphology of left bundle pacing, the leads were connected to the pulse generator. After that, reprogramming was done. And here you can see in bipolar high volt, you can see the QS morphology because of the tip is inside, because the anodal capture. You can see the image here. In low voltage, you can see the QR pattern. But in unipolar, both in high voltage and low voltage, you can see the QR pattern here. So this is the final ECG, post ECG, which shows a QR pattern in lead V1 and lead 2 is positive. So from the stim of the pacing spike to the QRS, you can see the isoelectric line. There is no myocardial capture. So it denotes you've done a selective left bundle branch pacing. So here I conclude. Conduction system pacing is feasible in most of the patient in post-AVR. Location of the aortic valve can be used as a landmark for conduction system pacing. And it helps to reduce the risk of heart failure, and it gives the best result for resynchronization. I would like to thank a special mention to my mentor, Mr. Jay Pratap, cardiac technologist, Cambridge, and Dr. Ulas M. Panturangi from Madras Medical Mission. Thank you.
Yes, thank you so much, Abhisha. So, do the moderators have any questions for Abhisha? All right, thank you. So, to present a memento for Abhisha, let me welcome Mr. Muralidharan. Can we give her a big round of applause? And keep clapping until she gets up the stage. Yes. Thank you so much. And our next speaker is Preeti P. On the topic Outcome of Conduction System Pacing Post-AV Modal Ablation from Madras Medical Mission, Chennai. Yeah, you can give her a big round of applause actually, not a silent one. Thank you.
Thank you. A very good morning, everyone. Myself, I'm Preeti, doing my internship program in Madras Medical Mission, Chennai, Tamil Nadu. And my topic was conduction system pacing in post-AV nodal ablation. Moving on to the introduction, patient who remains symptomatic and refractory atrial arrhythmia despite multiple antiarrhythmic therapies require permanent pacemaker implantation followed by AV nodal ablation. because the traditional RV pacing apex because the traditional RV apex pacing can lead to pacing-induced cardiomyopathy and increased heart failure hospitalization and mortality. To avoid these detrimental effects, a new concept, conduction system pacing, including his bundle pacing and left bundle pacing, was proposed as a potential alternative. Criteria for doing AV nodal ablation followed by permanent pacemaker implantation. The major criteria was ESC, which is the European Society of Cardiology, Class 2A AV nodal ablation, and ESC Class 2B for permanent pacing after ablation. Associated criteria are the patient who is suffering from drug refractory AF should undergo AV nodal ablation followed by PPI. Then the patient EF was reduced to 50%, narrow intrinsic QRS more or less than 120 milliseconds, and the age above 18 years. Moving on to the case example, a 87 years old male, known case of systemic hypertension and CAD, undergone multiple PCIs for complex coronary disease. He was recurrently hospitalized for drug refractory atrial tachyarrhythmia. Patient presented to the ER with a couple episodes of syncope. He was then stabilized. Later, even monitoring was done, which revealed sick sinus syndrome with frequent episodes of atrial fibrillation with fast ventricular rate. His LV function was mildly reduced with a EF of 48%, hence patient was admitted for further management. This was a serial ECG, showed sick sinus syndrome, that is the feature of tachy and brady episodes. The sinus pass was up to 2.5 milliseconds and frequent atrial ectopics noted. Episodes of sustained and non-sustained atrial tachyarrhythmias were documented at the rate ranging from 150 to 180 bpm with narrow QRS. This was the person's pre-ECG, shows sinus bradycardia at the rate of 45 bpm with narrow QRS. By achieving all the prior criteria, we have planned for AVJ ablation followed by a permanent pacemaker implantation with conduction system pacing. As prevention is better than cure, due to ablation complication, TPI was positioned on the RV apex. And we selected the proximal his bundle region for ablation. Why we targeted this region? Is because of the EGM. You can see the discrete A, H and V. The A is the atrial signal, H is the his signal and V is the ventricular signal. Once when you plan for ablation, that is the AV node ablation, one should get a discrete H signal followed by a signal and a greater amplitude of V signal. We then ablated and achieved a complete heart block with left bundle branch escape rhythm. As we ablated in the proximal region, the distal portion of the his came up to arise the escape rhythm. For pacing, we use the hardware like 383069 cm select secure MRI scan leads from Medtronic, also C315 his sheet from Medtronic. So by comparing with the EP catheter and with the 3830 lead, the 3830 lead have a special characteristic that it can map itself. After pacing, this was the signals we achieved. From moving on to 1.5 volt to 0.5 volt, there was a multiple morphology changes. In 1.5 volt, you can see a non-selective pacing, and in 0.5 volt, we can see a selective pacing with RBBB morphology. By screwing, the RBBB correction was done. So what is selective and non-selective pacing? The selective pacing just mimics the normal conduction system. So the QRS will be narrow comparatively with the non-selective pacing. It have a wide QRS. It have a QRS with a slurring pattern. That is, it is also called as pseudo delta wave because it captures the nearby myocardium too. In this slide, we can see in 1.5 volt, the pacing was non-selective, and 0.5 volt, by correcting the threshold, the pacing was with selective and accompanied with RBB. The local VEGM shows fused signal as it captures the nearby myocardium, and the local EGM in 0.5 volt shows a discrete signal with isoelectric line, which shows it was a selective pacing. First, in 1.5 volt, with the high voltage current, the lead was placed, so it captures the wide area along with the RV myocardium. So we have a EGM of pseudo delta wave. Then in 0.5 volt, we just minimize the threshold and it captures the conduction system. So we get a narrow QRS with the isoelectric line from the stem to the V. This was the final result we achieved with narrow QRS. After done with this, we placed the lead in the position. You can see his lead was placed in the distal position and the RA lead was placed in the appendage. For comparating with the ablation catheter and his lead, the ablation catheter was priorly positioned in the proximal region. Then the distal his catheter was placed in the distal region. Finally, the leads were connected to the generator. These were the measured parameters. The RA lead was around 1.1 volt at 0.4 pulse width, and the his lead was around 0.6 volt at 1 millisecond pulse width. This was the post-ECG of the patient. You can see the pseudo delta wave, discrete isoelectric line, and a narrow QRS. By comparing it with the pre-ECG and the post-ECG, we have nearly met the intrinsic rhythm. This was the beauty of the conduction system pacing. Take-home message: CSP is feasible, safe, and effective in patients undergoing AV nodal ablation. CSP with either his bundle potential or left bundle potential preserves or restores LV systolic function in patients who are suffering from refractory atrial fibrillation post-AV nodal ablation. Symptomatic AF patient treated with pacemaker and AV nodal ablation demonstrate improvement in cardiac symptoms, exercise duration, quality of life, and healthcare utilization. Thank you, everyone. My special thanks to Mr. Jayapradap and to Dr. Ullas M. Pandurani for mentoring us. Thank you.
Yes, thank you. So, do you have any questions?
To ablate AV nodal?
We used 40 volts, sir. 40 volts at 50 degrees Celsius for 240 seconds.
Single ablation or multiple?
Single ablation. Single lesion ablation. Thank you, sir.
Yes, thank you. And may I request Mr. Kesavan Kannan to present the memento for Preeti? Yes, thank you so much, Preeti. And next, we have Yashwant Elangorajan on the topic Loss of Biventricular Pacing from Madras Medical Mission, Chennai. Can we give him a big round of applause? Yes, thank you.
Good morning to everyone present here. I'm Yashwant from Madras Medical Mission, doing my internship there as BSc Cardiac Technologist. Okay, today my topic is about loss of biventricular pacing and what is the mechanism and the device response to it. So, before the introduction, CRT, we all know that CRT, cardiac resynchronization therapy, is a therapy we use for heart failure patients as a non-pharmaceutical treatment, which gives a more effective response than the other methods of treatment. So, the indications for the CRT is like severe LV dysfunction with a sinus rhythm, proceeding with an LBBB morphology, LBBB, and the QRS having wide QRS complex more than 150 millisecond. Coming to the BIV pacing, the maximum BIV pacing results in better response to the CRT treatment. So that like 97 to 99% of BIV pacing will give a best response to the CRT treatment. anything less than 94% will decrease the efficacy of this CRT and will not give an will give an suboptimal treatment of this for the patient. So 100%, 99 to 100% biweekly pacing is essential for a good results. Loss of biweekly pacing can be caused by many other factors, which will be discussed in the later slides. And another point is fusion may reduce the efficiency of CRT. So the fused beats and fusion beats, like both the biweekly pacing and the intrinsic is fused, will reduce the efficiency of the CRT. So here's a case I'm going to present with a 70 years old female with an history of diabetes mellitus, admitted for a heart failure hospitalization twice in a year, and now she is NYHA class 3. Her echo showed that LV non-compaction cardiomyopathy. Her ECG showed that sinus rhythm and left bundle branch block and reasonable wide QRS complex of 220 milliseconds, and her LV ejection fraction shows 20%, which satisfy the indications of severe LV. So as this history provides us that she is an ideal candidate for CRTD. Initially we underwent a conventional CRT placing that we didn't get a better results. We didn't get a narrow QRS and we didn't get most effective results in this conventional CRTD. So we switched to lot CRTD implantation. During the procedure, patient developed an cardiac tamponade, and after the cardiac tamponade, we did a pericardial synthesis, followed by an autotransfusion. The patient was stable after that. So here comes the ECG part. So this is the pre-procedural ECG, which shows an sinus rhythm and an LVBB morphology. So we are getting an VPCs of RV outflow, VPCs from RV outflow tract. So this with an normal axis deviation. So this was a pre-procedural ECG. After that, the procedure was done. The parameters was like the mode DDD, and the lower rate we have set it up to 50 millisecond. The upper tract rate is 130, and mode switch is 170. Phase length and JV delay is 190 respectively, and the VV delay is 0. That is simultaneous pacing. So after this, we achieved a good biventricular pacing. So the ECG was, we acquired a reasonable narrow QRS complex, which satisfies our aim, and we thought that we did a good job there. But in the afternoon, post procedure, the day afternoon, we got this as the result. So what we are seeing here is the ECG which took after the post procedural. So what we are looking at this slide is that the above strip is the ECG we acquired after the procedure, immediately after the procedure, and this is the next day to the procedure afternoon. So we are seeing that the morphology in the post-procedure, immediate post-procedure, and the day after that is different. What's happening here? Does this shows that any dislodgement or any loss of BIV? So we are look at this morphology. Look at this QRS complex. This we are seeing a dark line over this QRS, like spike on this QRS. Okay, what is this QRS? What is this spike on the QRS? So this one is the post-procedure ECG, and this one is the pre-procedure ECG. Look at this VPCs around this pre-procedural ECG. So this VPC resembles this post-procedural ECG. So here I'm saying that this ECG denotes that the junctional rhythm, LBBB junctional rhythm, has been accelerated, and which overtakes the BIV pacing. So we concluded that this is an accelerated junctional rhythm, which is denominating that pacing strategy we have made. So is this a loss of YV? Yes, this is a loss of YV. This is the ongoing trace we took that after the ECG, we found that this is the trace. So see here, we are getting the atrial rate at the top, and we are getting a V-sense BIV pacing at the bottom. So this is the mechanism that devices all acquired that ventricular sense response, which helps in this atrial tachycardia and atrial arrhythmias like. So they help in the ventricular pacing by fusing the intrinsic with this YV pacing. So ventricular sense response is that mechanism which to maintain the biventricular pacing in the patients with atrial arrhythmias and ventricular sense events. In non-tracking mode, the sense right ventricular event below the maximum rate triggers the VSR, that's ventricular sense response. In tracking mode, that right ventricular event during the AV interval, that is programmed AV delay, will trigger the ventricular sense response. So this is the final conclusion that this is the intrinsic. We got an morphology change after this first procedure. This is the fusion beat which combines that BIV pacing and this intrinsic rhythm. This is the actual BIV pacing we are aimed and we are acquired. So how to troubleshoot this? How we acquired that BIV pacing is to increase the lower rate of this CRTD. So we increase the lower rate so it could overtake the accelerated junction rhythm, and we can attain a actual BIV pacing to improve the patient's quality of life and the patient's LV ejection fraction. So this was the final parameters we have set. The mode as DDD, the lower rate as at 80 BPM, upper track and at 130, and mode switch as 171, and pace and sense AV delay as 190 milliseconds. And we actually programmed that VV delay as LV alone, which can cause more efficient pacing with this fusion with the intrinsic rhythm. So this is the cause of loss of BIV. I told that we were discussing in the last slides. So this is that the sinus tachycardia with short PR will cause an loss of biventricular pacing. Atrial tachycardia also is one of the cause. Ventricular premature complex and VVT, non-sustained or sustained VT can cause the loss of BIV. Incorrect programming of sensed and paced AV delay also can cause the loss of BIV. Junctional rhythms, like this, from this case we studied, right? Accelerated junctional rhythms can also cause the loss of biventricular pacing. Atrial undersensing and high LV lead thresholds can also cause loss of biventricular pacing. So take home message. The cardiac tamponade and pericardial pain caused by the exaggerated vasovagal response, sinus brady, and the jugular junctional rate overtakes. So while we are doing that case, cardiac tamponade has been, we got the cardiac tamponade. So this condition also promotes or overtakes or triggers the junctional rhythm to be accelerated. Ventricular sense response in CRT can also manifest in this fusion. Junctional rhythm can cause loss of BIV sometimes with ventricular sense response and fusion. Atrial pacing at slightly higher rate than the junctional rate rhythm solves the mystery. Thank you.
Yes, thank you, Yashwant. So, is there any questions for Yashwant? All right, thank you. So, to present momentum for Yashwant, let me welcome once again Mr. Radhakrishnan. Yes, thank you. And next, let me welcome Shantanu Bag on the topic of stabilizing of CS lead in CRTP, Amir Hospital, Kolkata. Can we give him a big round of applause and welcome him onto the stage, please?
Hello. Good morning, everyone. I'm Santanu from Amni Hospital, Dhakuria unit. And also thankful to ICVT Forum for giving me a chance to present here. Today I'm going to present stabilization of CS lead. And case scenario was 65 years old gentleman presented with heart failure and ECG shows left ventricular block and QRS duration wide on 70 millisecond. And ECG shows LV ejection fraction less than 25% and LVDP 55 mm. Septal to posterior wall motion delay 120 mm. And ECG shows, CAG shows status post PTCA, all standard patent proximal and mid LAD, minus CAD. And on examination, NIHA functional class 4, despite given heart failure medicine greater than 3 months, and ophthalmia, JPB pulse and tachypnea. And so, going to decide to do CRTP, as it is CAG shows minor CAD. That's why. And pre-CRT VAT and evaluation and dysfunction of LV and RV. These are the mechanism. Desynchronized electrical activation and mechanical LV mechanical desynchrony. And LV mechanical desynchrony and efficiency is decreased and rightward to shifted volume overload and increasing. That's why LV at remodeling and asymptomatic hypertrophy. And pre-CRT ECG, QRS is 170. And we take the venogram. Cannulating the CS to CPS lead. Those are the angiogram of CS. Passing the long sheath with CPS wire. And placing the quadripolar CS lead. And positioning the CS lead over the wire. And here you can see in the throwing the all system due to lack of support. And position it again. And we passing another wire parallel to the CS lead. So that wire was Sian blue wire, so that we can place on coronary stent to stabilize that lead. And we take 4.5 millimeter stent and deploy that 12 atmosphere. And deploying the stent, after deploying the stent, angiogram of CS. And filling that long CPS lead sheath. And this is the final position. and we get good threshold. And take home message is ECG by we capture, it device interrogate access spacing threshold and non-responding ECG optimization AV delay and VV delay. And CRT will regularly check its own battery, and the doctor will check to see how much energy left so that we can change that device on time. One more thing, at post CRTP ECG, Q will be decreased on 30 milliseconds. Thank you.
Thank you so much, Shantanu. So is there any questions for Shantanu?
We have bad forward sinus veins. What is the other option of placing the lead?
Actually, we did for only stabilization of lead. Sometimes what happened, we position the lead, and after during the pulling time, we throw all the lead. That's why we can sometimes we can dissect also CS. So on this side we can place on stent which is not obstructing the CS flow. So we can place that stent to stabilize that lead. Also can bad anatomy or tortuous anatomy, we also balloon that branch and place the lead.
Yes, thank you. And to present the memento for Shantanu, let me welcome Mr. Muralidharan. Can we all once again give a big round of applause for Shantanu? Yes, thank you. And for the next, let me welcome Shiv Dayal Singh on the topic of 10 must-known ECG for cardiac technologist from SGPGIMS Lucknow. A big round of applause.
Good morning to all. Today my presentation is on ECG and 10 must know ECG for every cardiac technologist. Look at this ECG. Look at this ECG. ST elevation in lead 2, ST elevation in lead 3, ST elevation in AVF. It may be either posterior wall MI or it may be inferior wall MI. If ST elevation is more in V2, lead 2, if ST elevation is more in lead 2 than lead 3, look at lead B1. If there is a tall R wave B1, it means it goes towards posterior wall MI, means due to circumflex. But if ECG looks like this, ST elevation more in lead 3 than lead 2, it favors towards inferior wall MI, means RCA. But something is more in this ECG. Look at lead B1. Look at lead B1. ST elevation is B1 and B2. If ST elevation with inferior wall elevation in B1 and B2 is there, or ST elevation in V1 and deep ST depression in V2 is suspect with inferior wall MI, there may be RV involved, RV infarction. So what to do? We have to take this B4 from left side, put it on the right side, you will see certainly ST elevation B4R. It indicates RV is also infarct. What is the clinical significance of this? What is the clinical significance of knowing that? If you know, if patient is cardiogenic shock, and if you know it is RV is also involved there, patient BP is less than 90, no inotoxil work. No inotoxil work. Infuse, lot of fluid. Infuse, lot of fluid, BP will come up. So please note it. In this slide, patient came with history of chest pain, but at present his ECG is within normal limit. Trough is slightly elevated, but he has some ECG, previous ECG. Look at V2. Look at V2. Look at T wave, biphagic T wave. There is a biphagic T wave. This sign is known as valence sign. This is valence sign, either biphagic T wave or deep inverted T wave. It is valence sign, and it is very critical. You will see if there is valence sign, LAD 99% stenosis, 99% stenosis, flowing but 99% stenosis. So please respect valence sign. In this piece ECG, call came to you from ICU. Patient is on paracetamol drip for STMI. Patient got STMI. Look at this ECG. Look at this ECG, V4, V5. It is not ST. It is J point elevation. J point elevation. You can see a wave here, J wave. This sign is known as Osborne sign. This sign is known as Osborne sign. This is not MI. And if you know this, it is Osborne sign. The choice of treatment is only 2 blankets, not more than this. Because patient is in high paracetamol drip, so this sign comes when patient is hypothermia, cold enough, hypothermia, because patient was on paracetamol drip, so this change has come. Look at this ECG. Patient has chest pain, severe chest pain, ST elevation all around. You can see ST elevation all around on all the leads. But look at AVR. PR segment elevated, not ST segment. PR segment elevated in AVR. PR segment depressed all other leads. You can see here. PR segment depressed all other leads. ST depression in AVR. If there is PR segment, ST elevation all around, no reciprocal changes anywhere, PR segment elevated in AVR, PR segment elevated in AVR, PR segment depressed rest of the lead, please suspect acute pericarditis. Please suspect acute pericarditis. Look at this ECG. Look at lead V4, V5 or V3. Like this V3, this is highlighted here. Deep ST depression, upsloping ST depression, deep upsloping ST depression. The name of this sign is not De Winter sign. The name of this sign is De Winter sign. And if you pick up it here, it means LAD 100% occluded. LAD 100% occluded. Not ST elevation, even then LAD is occluded. This sign is known as De Winter sign. So please recognize this sign. Look at this. Patient came to you with complete heart block, history of CKD, chronic kidney disease, and in CHB, but he has some serial ECGs, previous ECGs. Look at this T wave. Look at this T wave with CKD patient. Tall T wave, narrow base, tall T wave, narrow base, CKD patient, suspect hyperkalemia. Suspect hyperkalemia. Check his potassium. If it is around 6, this sign comes. First sign comes T wave, tall of T wave, narrow base. After if potassium goes around 7, all complexes are stretching. QRS becomes broad. P wave disappears. T wave flattening. Look like AIVR, accelerated idioventricular rhythm. Don't confuse with BT. So it is, and after if potassium goes above the 8, patient may develop CHB like our patient. So the treatment of choice is not pacing. Treatment of choice to correct the potassium. Infuse calcium gluconate. Infuse dextrose with insulin. You will see CHB will go off. So please recognize hyperkalemia. In this ECG, patient came to you. Previous patient came to you like symptom of LVF, left ventricular failure, dyspnea, cannot sit. But his previous ECG was normal. Look at this ECG. Look at lead 1. Look at lead 1. First it is look at this all ECG. This is tachycardia. Look at lead 1. There is deep S wave. Deep S wave. Look at lead 3. There is Q wave or T inverted wave. S1 Q3, T3, tachycardia, rule out pulmonary embolism. Rule out pulmonary embolism. Look at this ECG. Look at this ECG. Sinus rhythm, short PR, hockey stick early repolarization. It is WPW sign. First ECG, WPW. Patient may develop AVRT. Look at that ECG. Look at in B1, pseudo R is there. Supraventricular tachycardia, no P wave is seen there, but P wave is hiding in this pseudo R. This pseudo R is due to P wave, is retrograde P wave. Look at inferior lead, ST depression, because of not ischemia, it is because of P wave is hiding there. So it is AVNRT, nodal tachycardia, it is AVNRT. This one is WPW and this one is AVNRT. Look at this ECG. Here, there is RSR pattern. It is only RBB. You have to understand which is RBB and which is trifascicular block. RSR pattern, only RBB. It may be benign. But look at this ECG. RBB is there also. But left axis deviation is here. And with left axis deviation, look at lead 2, lead 3, AVF. All are identical. If RBB is there, left axis deviation, lead 2, lead 3, AVF, all are identical. Left fascicular block is also there. It means it is bifascicular. And look at PR interval. PR interval is prolonged, more than 200. It means it is trifascicular block and patient may need pacemaker. So if it is trifascicular block, patient may need pacemaker. If it is only RBB, it may be benign. Look at this ECG. Lead 1, all complexes are negative, P negative, QRS negative. Look at AVR, all complexes positive, QRS positive. If you see lead 1 negative, AVR positive, go immediately precordial lead. Look there, search there for R-wave progression. If R-wave progression is in increasing order, it means it is, if R-wave is in a decreasing order, it means it is heart is not there. It means it may be, it is dextrocardia, heart is somewhere else. But in same ECG, if lead 1 is negative, AVR is positive, but in precordial lead, R-wave is going increasing, it means heart is there, something is gone wrong. We have misplaced the lead. And which lead is negative? Lead 1 is negative. We have misplaced right arm to left arm to right arm. Thank you.
Yes, thank you so much, Shiv Dayal Singh. Is there any questions for Shiv Dayal?
Thank you.
Yes, thank you. To present the memento, let me welcome Mr. Kesavan Kannan. Yes, thank you. And next is Mohammed Amir Akhtar on the topic of a
in Apollo Multi-Specialty Hospitals. So today my topic is hybrid and drilled disturbed approach of treating heavily calcified coronary lesions. So right now you have listened lots of physiology and ECGs. My topic is different. So the patient, the history patient 61 years male presented to the ER. History of chest pain and clinical diagnosis hypertension, diabetic mellitus, obese, non-established MI, suspect ACS. The ECG has a right bundle branch block, echo 60%. So we plan to do the angiography and as well as the reverse visualization. So we did a right coronary angiogram first. This right angiogram reveals there's a ostial minor plaque with ectasia. There's no such block, and there's a ectasia. And this left coronary angiogram shows the OM has a critical lesion along with long calcified lesion in LAD. And there's a D2 which totally occluded and retrogating. This is spider views. So it's come almost the ostium of the LAD. This we plan to do the either CABG, send for the CABG, or we do the angioplasty with multiple stenting. But as the patient has refused to do the CABG, so we plan to do the angioplasty. So we did a first OM angioplasty with did a 3 into 12 balloon, and then we placed a stent 3.5 18 DS drug-eluting stents, and this is the post dilation. After post dilation, we did a IVAS. So IVAS shows a well opposed stent. There is a no mal opposed or something, and there is a no edge also. So we after final angioplasty, the IVAS lumen minimal area we got 8.2. That is which is a very satisfactory. So we did after that we did a pre-LAD IVAS, which in IVAS you can appreciate the very heavily dense calcium in the around 360 degree. As we see the LM, there is also some plaque shown. There is a 44% percentage, and the distal LAD lumen area we got 2.04, and the mid LAD and proximal we got a 3.8, which is very critical. So we plan to do the rota first. We did a rota pro 1.5 mm bar. And then after rota, there is still not lumen achieve what we get. So we plan to do the shockwave 3.5 into 12. Total 80 impulse we have given, each cycle 10 impulse. So we did give over from distal to all proximal, even proximal LM. So after IVAS and rota and I will done. So we got the lumen. There is a calcium cracked also. You can see the calcium and flap this area around 9 o'clock. Then we final dilation with NC balloons distally 3 into 15 and proximal 3.5 into 15 to make the stent trackability good. And then after we plan to do the distal BVS because we are going to do the distal LAD stenting. So in case there's a heavily calcified, in case may future required CBG. So at that place we kept the area to put a graft. So we did distal BVS, and then proximal we put a DS stent 4 into 18. And LM stenting we did 4.5 into 30. Allocranial is which very promising views to show the ostium of LM. So after stenting, we did a post dilation proximal 5 into 12, and then we recrossed the circ wire, and we did a 4 into 15 distal stenting, as well as the distal BVS we did a 3.5 into 12. So this is the final result, and we did IVAS. The diagonal was still retrogating, so we couldn't approach to open. It may required bifurcation also, if we. So we don't disturb the diagonal. So after stenting, we achieved the distal 7.95, almost 8, and proximal we got 11.58 lumen area, and LM we got 18.16. So this is the final result. Sorry. There's no L6 ostium pinch and flowing well. So overall summary, the imaging guided PCI helps us to understand the lesion morphology, arc, depth of calciums in nodules, severe calcium, so that it helps to therapy modalities for the optimal outcomes. The calcium lesion means percutaneous intervention result to suboptimal the increase the risk of posterior complications and future adverse event. The rotatripsy, the combination of rotatherapy, arthrotomy and the intravascular rotatripsy for the treatment of the severe heavily calcified lesion. The rotational arthrotomy allows the treatment of intimal calcium permeates to cross the balloon and stent through the severe lesion. However, it may not enough to achieve the adequate expansion of this device if the circumference deep calcium plug exists. The sonic wave travels from the balloons to base catheters surrounding the tissues and selective breaks the both superficial and deep calcium deposits. The shock balloon processes the revolution tool to treat the deep calcium undilated plug. However, it cannot be easily delivered through the severe diffuse lesion, its bad crossing profile. The combination of these techniques, that's called rotatripsy, make useful the percutaneous treatment for the severe de novo calcium lesions. Thank you.
Thank you so much, Mohammad Hamir Akhtar. And to present the memento, let me welcome Mr. Radhakrishnan. Sorry, is there any question?
Maybe if you had already planned for IVL, why you did the rota first?
Actually, there's the rota IVL balloon crossability is very bad. Yeah, before that is what not going. Even the 2.5 NC balloon was not crossing.
But that point you didn't tell me.
That I missed that. So that we do the rota and then followed by rotatripsy. Yeah,
one question, Amit. As you have shown, the angio has shown that LED ostium has 95% to 99% disease. So why you should not use pre-dilatation balloon before getting the rotameter 1.5 bar?
We tried the 2.5 balloon, but what was crossing?
You have not shown it.
That missed.
Okay.
Yes, thank you. And to present the memento for Amir Akhtar, let me welcome Mr. Radhakrishnan. Can we give him a big round of applause? Yes. Yes, so by this we have come to an end of electrophysiology and pacing session. So is there any discussion between the audience and the moderators? If you have any questions to the moderators, you can ask regarding the session we just completed.
If the audience has any questions, they can come forward and ask the moderators. Any questions, any doubts, any queries?
If there's any questions regarding electrophysiology and pacing, you can come forward and ask the moderators. like to ask the moderators.
behalf of SPCIT Association India,
in keeping the upliftment of knowledge,
bring all of us into one platform in the national event.
Thank you very much, and I am looking forward to seeing you at the conference.
Structural intervention. We have two presentations coming up. For that, let me welcome first Ramesh Rathinavale, topic bilateral PA stenting and pulmonary valve implantation from Apollo Children's Hospital, Tamil Nadu. Can we give a big round of applause, and can I request you all to please be seated? Yes, also, I request you all to come forward and so we have so many vacancies in the front row.
Good morning, everyone. I am Ramesh Rathinavale, Senior Technologist in Apollo Hospitals. A warm welcome to one and all gathering here. A big thanks to each and everyone present for this occasion. Just you can see these slides. After I tell them my presentation. This is my presentation, percutaneous transcatheter fontan completion. This procedure is doing surgery or catheter, transcatheter before minimum doing the surgery, one surgery or two surgeries. This is BT shunt or gland. These two surgeries done after only doing the quantum surgery. Now it's going to my topic. Case history. 7-year-old female. She was diagnosed to have heart disease, TGA, VSD having and hypoplastic RV with severe pulmonary stenosis after birth. She had stage of the first palliation at 6 months of age, followed by LPS stenting 2 months back. Patient had history of cyanosis and poor weight gain, no history of the syncope and dyspnea and exhaustion, chest pain or palpitation. Clinical diagnosis. First correction, bilateral BDG plus atrial septostomy plus MPA interruption for TGA, bar VSD, hypoplastic RV, pulmonary stenosis and hypoplastic LPA, PDA done on June 2016. Well functioning for the bilateral BDG. Now flow reversals in no flow reversals in good size and confluent branch pulmonary arteries. LPS stenting was done in June 2022 plus MAPCA coiling also. Good ventricular function. Examination of the baby. 7-year-old, weight for 19 kg, height 120 cm. She had a grade 3 clubbing with the saturation for 70 on the room air. Echo showed for the good function. LPS stenting is a 10-30 Cook formula. MAPCA coilings for coils used, Cook coils. She was discharged on oral stenting. After LPS stenting, she was discharged on oral sildenafil and the aspirin for 2 months. After doing the diagnostic angio, signs PA pressure were in the mild elevated. So diffuse PAVMs, and thereafter discussed with that MD senior doctors, multidisciplinary team and cardiothoracic surgeons. These both are recommended for the CTPA angio, CT pulmonary angio, finding PA stump and adherent over the cranial end of the RA near to SVC to RA junction. This angio I can show it later. Idea for percutaneous Fontan, as she is a high risk candidate for surgical palliation. So decision was discussed with parents, and after that consent transcatheter Fontan palliation. This is the before LPA angio, LPA stenting angio. 5 French pigtail catheter was taken through RAJV Glen injection. LPA stenting done on the June 2022. Embrace the map cause also. Glen pressure was 21/15, mean of 18, LVEDP 13, Cook formula size was 10/30 used. This is the LPA stenting. After stenting image angio. Now going to procedure. A 5 French pigtail catheter was taken through RAJV and same time RFP. Both pigtails doing the simultaneous injection done in the Glen and IVC injection. So reason for how to distance straight line or how to differ. See the angio. The MPS stump in the IVC to RA junction was straight line and close to each other. Through RAJV, Jackson side catheter was exchanged to 8 French SL1 dilator. This dilator using to idea give to my teachers, Mr. Andrew. He is using for a lot of techniques, so I can implement to my doctor that time. So only SL1 dilator taken, dilated with a broken borrow needle. This is a puncture to the exact origin. You can show this angio. This is explained. Broken borrow needle, MPS stump was punctured. The needle was taken out, heparin given after puncture. A O25 thermowire was taken through the gland and placed into the RA through RFP. 5 French guide catheter with snare it out, advance into the RA. The O25 wire was snared and taken out through right femoral vein. This is the angio I can show you. So first I can tell you BT shunt after Glen. Glen was doing the SVC to connect a PA. Fontan surgery. Fontan surgery was doing to the IVC to PA. This patient was not fit to the surgery. That reason I discussed with parents and after doing transcatheter. You can see now RA junction and then PA near straight line. Now this is a SL1 dilator. Sorry. This RAJV is a SL1 dilator with septal broken borrow needle punctured after put the 2.5 thermowire right femoral vein through guiding catheter with 30 mm snare, pull it out. And after exchange to the RAJV, exchange to 8 French sheath. This is RAJV 8 French sheath injection, simultaneously right femoral vein pigtail injection also doing. Stent was entry. RAJV sheath was upgraded to 8 French sheath. 5 French catheter, Jackson side catheter along with the O35 wire, 260 centimeter. Thermowire was snared with a 30 mm snare and taken out the through right femoral vein. A Landerquist wire was pre-launched for the 260 centimeter thermowire through the left femoral vein. 5 French pigtail catheter was advanced and kept in right atrium for all injections doing. So preferably plan to that 3 axes. One is right femoral vein, right femoral artery, left femoral vein and RAJV. This is stent entry. The stent for Z5 XL 24 into 59 mm. My Tamil Nadu patients are all and the poor peoples. So this is for trial stents. total cost of the patient free. That reason only approach to the patients. Everything. This is for post balloon. Now seeing that how the injection and PA to IVC, how close. Now taken to 29 mm stent and a bib balloon. Bib balloon for 20 into 4.5 centimeter length. Why take the bib balloon? There's a reason for inner balloon. Adjust to the stents. Positioning adjust, not a stent. Stent was deployed nicely. So after I can take the self-expandable stent. What is the, I will take the self-expandable stent. So all are the open cell stent. So cover stent need to that RA junction. Self-expandable stent post angio. Self-expandable stent after post ballooning. 26 into 20 mm Atlas Gold. This is a high pressure balloon. The market also not available to any other companies. High pressure balloons. That balloon only available to the 26 into 20. This is also maximum length for 20 only. Now see how do the flows. P angio also nice. This is the final angio. This is for palliation correction only. Patient life. Sheets 4 numbers, guide wires 35 and 150 cm, 260 cm and 25 guide wires, lander cost wire 260 cm length. This is snare 30 mm pigtail and jackins right. Must you keep in that always 12 French and 14 French long sheets, braided sheet and then long sheet is better. The length is minimum 75. Above the 70 is the better always. And 24 stenting was already fixed, measure the angios, diagnostic angios I have it. So measure that length, that way I will select stents. 24 into 59 mm Z-Fire XL stent, 29 mm Z-Fire XL stent, crimped for over the 20 into 45 mm bib balloon. Atlas Gold for 26 into 20 post dilatation. Endurant 2, 25 into 49 mm graft stent. This is a cover stent, RA junction, not leaking to the that side going bloods. We have to back up cover stent also. Always cath lab I can do, we will do the cases, I will arrange. Without cover stent, I am not taking the, not put the patient in the cath lab. Any RUT stenting, coagulation stenting, I will do LPS stentings also. I can minimum, otherwise are not available into the market. I can inform to the consultant that this stents is not available, market is also not available. Just you can check with your side. This is a summary. Transcatheter fontan completion without pre-surgical condition, a feasible option of the children with a favorable anatomy with risk factor for surgical palliation. This is a surgical image. This is for stent image. So surgical also create the one small PFO same like. This also my angio also I can show you. Some blood flow is going. You can see. Now we can see the surgical image. Create on the flow is there. So thank you.
Thank you so much, Ramesh. And is there any questions?
Very nice presentation, Ramesh. What is the long term and follow up of this patient?
So every 3 months once patients follow up, sir. It's a compulsory. I can follow this patient on birth to follow up that hospital. So that patient is a very poor patient. So he is support with you, fundraising platform.
What is survival chance?
Survival chances. So it's a palliative only, sir. Survival is, I like to patient life extended. Patient life is I can extending. So that patient taking the previous Fontan competition, 70 is in the room air saturation. Now 85, sir, after stenting. So this is maybe our patient 6 month Glenn surgery is done. So now for 7 years. I like 7 years also extend means. So I am happy and God is God in this. That patient life. Thank you, sir.
Thank you so much, Ramesh.
I have a question. It was nice presentation.
Thank
So why you are using the second stent?
This is the main reason. This is for
You can put the cover stent from the first stent. Why you are using the
You
small?
can put the first stent for cover stent. I can show that. Sorry, ma'am. You have to change the slide. Bro, previous slide. Yeah, I can show, sir. Yeah, listen, just I can tell you the reason. You can tell him this stent, you can take a long stent. Okay, long stents I don't have that in the markets. First reason. Okay. You can tell him that stent, why you cannot take the cover stent, correct?
No.
Your question?
My question is that why you are using the second stent? After that, you can use the cover stent from the
endurance.
No. After that, after dilate the first stent, you can covered with cover stent from the first stent. Why you are using the second stent in between the small stent?
This is not connected to the PA. No? This is not covered to PA. Just enter the RJ junction only. This stent. So need to PA to RA. Full length covered. PA to IVC covered.
Show me the next slide.
Yes. Yes, sir. Hello, sir. Slow system. This stent.
Yes. Here you can you put the cover stent from the first stent?
It is covered. Patient is not offered. This is a free of cost. Everything. All stents free.
By mistake they misplaced. They're not able to cover. That's the reason they're taken another stent. They can push it back. No, they don't need for cover. So they go over second stent in the distal part.
The full length cover plan was PA to IVC covering. This is so total length 59 mm plus 29 mm. You can think 60. So 79 mm stent needed requirements.
Okay.
I need 79 mm stent length. I have the angio.
Length is not there. The second one is they misplaced the position. The third one is we can take another stent. We can put in the distal part. So now what happened? The three stents are three junctions. One is the main, another one is small, one more in the top.
The top for self-exam is a covered position. Endurance graft stent master always is a covered stent. So this is for not like RA to not blood going stent. This is open cell stents.
Got it.
Blood going. That reason only that is. This is also giving to that 30% something concession to that discount the patient. Fundraising platform.
Got it. Thank you.
What stent are you using for LPA?
LPA cook formula 10/90/30. Yeah, this is for here using 6 French sheath and 7 French sheath. Very easily going to maximum 10 mm stent going to 7 French sheath. It's a balloon mounted stent also.
And if there is a 6-year child with a PD and walk test, so we'll put a cover stent. So what stent will we use?
You can use a live stream.
Live stream is how much compared to
Maximum 7, 8 French or 9 French. This is a beginning starting to 6 French live stream stent.
But
No, no. You can take as what is the length, what is the dia. Just measure pre-angio. After only you can. Less than 12 into 40. You can use any PDA is there or not there. With PDA with coarctation. PDA is, I mean, PDA, how big PDA? 4 millimeter means you can put that 6 by 4 PDA device and put that 10 into 30 Cook formula strength. This case also I have that one presentation is there. You can see. Okay, you can go the job on cover strength. Cover strength means need to the bigger sheet. Yes, sir? Advanta V2 now not came, no? This is the old, is a balloon mounted stand, atrium. I am also using 3 stands, atrium 12. So now it's not came to the market. That's a drawback. Manufacturing is not there. Maximum 7 French. This one cover strength need to 8 French. Live stream also 6 mm and 7 mm dia is comfortable for 6 French sheet. CP always you can take the balloon depending on the balloon and then over the 3 French extra. If a balloon for 10, you can take the 840 balloon, Cook balloon. This bar 6 French sheet comfortability. So 3 French extra, 11 French sheet you can take. Minimum 2 French extra. It's a cover set always you can take not a 2 French, 3 French is better always. Recommended he is recommended for 3 French. Okay, thanks.
Yes, thank you. 1 second. To present the momentum for Ramesh, let me welcome Mr. Muralidharan. Can we please give a big round of applause? And next is Padmaja. Okay. All right. Okay, so we will be resuming the session by 2 o'clock. Yes, thank you.
Check, 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 check. Check, check.